Hello, everybody. Welcome. Thank you so much for joining us today. My name is Bob Gabe. I'm the Chief Scientific and Medical Officer here at the American Diabetes Association, and I'm really pleased to have two special guests today to talk about a really important issue, and that is kidney health, something that is near and dear to people living with diabetes. And so thank you so much for joining. I have two wonderful people here, and I will ask them to introduce themselves. They have a wealth of background, and they're going to be the source of a great conversation. I will also ask you in the audience to throw questions in the chat as we go along. This is going to be conversational, and we want to get the most we can out of this. I'm just going to fix my camera while I'm at it. Oh, you know how that goes. All right, here we go. Here we go. First we have Tina Lividay, and Tina, I'll let you introduce yourself.
Yeah, sure. Thank you so much, Bob. As you just stated, my name is Tina Lividay, and I have the pleasure of being the Chief Nursing Officer for DaVita, and have had quite a journey there in terms of spending my career there and dedicating my life to my work's passion around caring for our patients with kidney disease. So I've been there for 26 years now as a registered nurse, and in multiple leadership positions throughout the organization, and then most recently as our Chief Nursing Officer. So I'm really glad to be here with all of you today.
Excellent. Thanks, Tina. And then we have the big cheese, Dr. Jeffrey Gillian.
Thanks. I don't know that anybody's called me the big cheese, although I have a 14-year-old daughter who thinks I'm cheesy. So I'm not sure that's a positive thing. I'm Jeff Gillian. I'm a nephrologist from Denver. I was in practice in Denver for about a decade, and I now serve as the Chief Medical Officer for DaVita Kidney Care. So great to be with you today. Great to be talking kidney disease and the things that we can do to prevent progression of kidney disease, especially in our patients with diabetes.
Thank you. Thank you. And I hope everyone enjoys a little bit of humor. It's Friday afternoon, and we want to share as much information as we can. So I'm going to jump to questions again. Put questions in the chat. Tina, I might have you set the stage for us. Chronic kidney disease, big problem for people with diabetes. Who's at risk?
Yeah, sure. I think there's several risk factors that we can talk about for kidney disease for sure. And I think, in fact, I think it's important for everyone to realize that 1 in 3 adults in the United States are actually at risk of developing chronic kidney disease. And about 37 million of adults today actually have CKD and aren't necessarily aware that they have kidney disease. And there are many risk factors such as heart and cardiovascular disease, smoking and obesity, but I think the two leading risk factors, and ones that we want to particularly talk about today, are high blood pressure, hypertension, or diabetes. And in fact, out of about 3 out of 4 new cases of kidney disease are a result of one of these two leading risk factors. And so in terms of diabetes, we know that patients who do have diabetes have a tendency to have high blood glucose and blood sugar, and essentially over time that can damage the arteries and the blood vessels around the kidney, which ultimately lead to kidney failure potentially over time. And then similarly with high blood pressure, similar effects on the kidney and ultimately risk factor for failure of the kidneys. And I just think it's really important that those with diabetes understand their risk factors, since both diabetics as well as hypertension are the leading risk factors. There's a huge amount of risk to our diabetic population because they have a higher likelihood to actually have both of those risk factors. So we know diabetics are 2 times as likely to have high blood pressure. And so there's just a significant risk factor for this population of patients that we want to be aware of as healthcare professionals. And I think even more importantly, we want them to be aware of as it relates to their risk factors and how to address them.
Absolutely, and that's part why we're doing this program, because of the high risk. And so diabetes and hypertension, as you said, are three out of four cases, and people with diabetes often have hypertension. So how does one make the diagnosis? Jeff, I might turn to you.
Yeah, the diagnosis of kidney damage or the kidneys not functioning as well as possible is usually made on simple laboratory tests, a basic metabolic panel, a Chem7, where we can see a creatinine and a urea, a BUN. And these lab tests tend to, tell you approximately what the kidney function is in a given person. And then for either a primary care physician seeing the patient or the nephrologist, then it comes down to getting more information about what's going on to determine whether or not it's diabetes causing the issue or something else causing it. So we often do urinary studies. We look at the amount of protein in the urine. We typically try to take a look at the overall history of the patient, how long they've had elevated glucose, what their hemoglobin A1C has been, not just as a snapshot in time, but over time. And typically we can make a presumptive diagnosis of diabetic kidney disease based on history and laboratory findings, including blood and urine. Occasionally, including in my own practice, sometimes we have to go more in depth and actually do a kidney biopsy, take a look at a little piece of tissue under the microscope to make a determination. But I would say, that is rarely the case. That's the exception as opposed to the rule. I do want to build off of something that Tina said, just because it got me thinking about it. I've often talked to my patients about sort of the trifecta, the three biggest risk factors. Tina mentioned two of them: diabetes and high blood pressure. And then, unfortunately, this is not a fair disease. Diabetic kidney disease is not fair. It tends to hit people of Black ancestry, Hispanic ancestry to a greater extent than those of us that are Caucasian. Doesn't mean that we are immune from it. But I used to talk about the trifecta, and people, get one strike, that's high blood pressure. They get two strikes, that's diabetes. They get three strikes, that's their genetic heritage. And all of a sudden you run the risk for declining kidney function. And ideally, we can intervene early enough to help slow that down, both with medications and lifestyle changes and things along those lines. But if not, then we have to prepare for kidney transplant dialysis. That's never, ever the goal, but it is one of the reasons we're here talking today, because early prevention, early identification, early treatment, it really matters.
It certainly does. And we'll get to the later stages. But as you said, it sounds like the diagnosis is largely clinical with laboratory data. And
exactly.
And if you had to put your money on two or three tests that are really going to sort of tell you, we've got busy clinicians there.
Yep. So I want to know, when I'm seeing a patient, I want to know what their estimated GFR is from creatinine. There's been a lot in the news about that lately, about changing the way that estimated calculation is done, taking race out of the calculation. I am in full support of that. So knowing what the eGFR is from information from the BUN, from the creatinine, that's number one. Number two is looking at the urine. If there's one thing I'd want to get across to my primary care colleagues is, let's check for albumin in the urine. Let's check for overt proteinuria in the urine. It doesn't have to be a 24-hour urine collection. A spot urine collection, spot urine protein to creatinine ratio is very, very helpful in this diagnosis. And then third, I want to know what the hemoglobin A1C is and what it's been. If I have those three pieces of evidence, I'm not a perfect diagnostician, but that gives me a lot of data to go on.
You're most of the way there, absolutely. And maybe it's helpful because I see this misconception a lot of times. So a urinalysis, how sensitive is that versus you describe the urine albumin creatinine ratio?
Yeah, the urinalysis itself, which is the dipstick test, gives a little bit of information. Of course, it's open to interpretation, and it's qualitative, not quantitative. It does not take much more. It's that same just urine sample to get a spot urine protein, a spot urine creatinine, And to do that calculation, a lot of labs actually do the calculation for you if you order it properly through the electronic health record. And so I would just say I think it's always beneficial, at least once a year in these patients, to check a spot urine protein and creatinine.
Absolutely, and that is part of the ADA standards of care to do that, and EGFR on all people. Tina, how do you sort of have that conversation with people living with diabetes to say, without scaring them too much, but making them realize, this is important to pay attention to?
Yeah, I think it's, I guess my perspective has always been as a nurse and a caregiver is that I want to empower my patients to know what their risks are and to advocate for themselves in their own healthcare. And so I do think it's a fine line as we walk as healthcare professionals, because obviously we don't want to scare our patients, but we want them to recognize what the reality is of their situation and what they can do to address it and take control over their own destiny. And so as what Jeff mentioned, I think it's super important that we educate our patients in terms of what their risk factors are. And there are a lot of tools and resources that we can support our patients in doing that. And we can talk a little bit about them later. But I think it's important for us to educate them on their risk factors and on the recommendations that you mentioned, as well as Jeff, around the fact that they should have annual screening by their physicians. And so from my perspective, it's super important to empower our patients that they know that that's a requirement and something that they should have access to and be aware of as they're moving along their journey with their chronic condition. And then I also advocate for my patients to make sure that they understand how important it is, especially for a diabetic patient, to ensure that they're focusing on maintaining their blood sugars within the targeted ranges. And the fact that, as Jeff said, that seeing an A1C and what that means for them as an average over the last 3 months can really be impactful in terms of how they can think about their healthcare with their healthcare provider. And then the other, just I guess, easiest and simplest thing I would love to suggest to our patients is that one of the most important things that they should be doing, obviously, is following up consistently with their healthcare provider and taking medications as prescribed to ensure that these chronic conditions, diabetes as well as hypertension, remain controlled and don't escalate along their journey to chronic kidney disease.
Yeah, because this is preventable, and
Yes.
that's the important message. And I like that idea of empowering people to take control of their own health. And it's something that we've been witnessing, and I suspect you all have. Because of the pandemic, people have delayed care, and so the screening hasn't been happening, but now it's time. And so doing outreach to people with diabetes to get them in and get tested, get screened, because sadly many people even pre-pandemic were not getting screened and often discovered later along. So Jeff, maybe on the medical side, so what kind, okay, you helped us with the diagnosis, and we do those tests, and now okay, they've got presumed diabetic kidney disease. What's sort of the medical management, and then maybe we'll segue into some of the new exciting treatments that are out there.
Yeah, I've always sort of, I guess, divided in my own head medical management into things that we know directly are helpful, and then the things that we think of as indirectly helpful. So the directly helpful ones are the class of medications, the ACE inhibitors and the angiotensin receptor blockers. Those tend to be beneficial for patients regardless of why they have protein in the urine, proteinuria. We want our patients on those medicines. They have the dual effect of improving blood pressure and probably cardiovascular health, and in directly impacting kidney function. Sometimes it gets a little tricky because you start those medicines and the creatinine tends to go up, EGFR temporarily goes down, and there's often a worry of, oh my gosh, have I made things worse as opposed to better? Most of the time, though, the long-term effects are positive, a slowing of decline of deteriorating kidney function.
I'm going to put a pin in that, because that is, I see that as a common misconception, that you may see some change in GFR that looks like it's a problem, but it may not be.
Yeah, I don't want to bore everybody with it, but I'll geek out for just a minute and sort of thinking through the pathophysiology on this. And I'm not an expert, I'm not a researcher. I'll put all those caveats around this. But what happens, especially early on in diabetic kidney disease, is you actually get hyperfiltration at the glomerulus, at the filter of the kidney. You get a dilation of the afferent arteriole, that's the artery going into the glomerulus, and you get a little contraction of the efferent. So you increase blood pressure inside of the glomerulus. That means that you just like a fire hose, you're pushing that fluid out through the filter at a higher pressure. So you get hyperfiltration. The creatinine actually goes down in the earliest stages of diabetic kidney disease. It's the opposite of what you'd think. Kidney function looks better. It's not, but it looks better. When you add the ACE inhibitor on there, or the ARB, you get dilation of that efferent arteriole. So you're lowering the pressure, the blood pressure inside the glomerulus. So you get less filtration, creatinine stays in the body, and hence when we draw blood, creatinine level goes up. And it looks like, oh my gosh, I've started this medicine and I've caused the kidneys to get worse because creatinine's gone up. That's not the case. What you've done is you've lowered blood pressure where you need to lower it the most. And so it's an area where I think we need to talk about a little bit more, because there are some patients in whom the creatinine goes up so much you do have to change those medicines, and we need to think through those rare cases. But most of the time, creatinine goes up 5% or 10%. That's well within the standard for these meds, and it actually means to me, hey, we're doing something positive for these patients.
Yeah, that's a good clinical pearl, because I my experience is that that's a source of confusion. Tina, what kind of lifestyle things can we advocate for our patients when they're diagnosed with diabetic kidney disease?
Lifestyle changes?
Yes.
Yeah, I think so I would say first and foremost, it's going to be extremely important to understand the needs to maintain a healthy diet when you might have diabetic kidney disease. And it's extremely important to discuss that with your healthcare provider in terms of what that exactly should look like. We have ample resources and tools in order to help assist with that, with both on diabetes.org, but also on DaVita.com. I know Dr. Gabe, we've partnered pretty strategically together to ensure that the recipes and the dietary recommendations that we have on the diabetes.org website are also kidney friendly. And so it's a great resource and great access for healthcare professionals, but also for patients in terms of how to take care of both, right? The ADA portion of the diet, but also the renal friendly portion of the diet. And then I would also recommend that, for our patients who have diabetes and also at risk for CKD, exercise regularly. I think it's extremely important for all of us, especially through the course of the pandemic. I think we've all recognized that, stress can certainly build up, and that's true for us. It's true for our patients. And there's a lot of health benefits as it relates to a level of activities throughout the day. And so we definitely recommend that. And then obviously all of the other good things that go along with health, just a healthy lifestyle. So a limitation of smoking, alcohol consumption, et cetera, because all of those things are just compounded risk factors for any chronic condition, but especially those that have diabetes as well as hypertension that could create a greater risk for CKD.
Great. And so I'm gonna turn to you, Jeff, get a little deeper into the medical management. So we want to control blood pressure, ACEs and ARBs, and then of course glucose control, because that's the driver of this. And then there's some new medicines, and that's been an exciting story. If you want to share a little bit of that.
Yeah, it is exciting because, innovation always comes in spurts. And what we've seen is a real spurt of innovation in the medical management of diabetes and kidney disease very recently. So a class of medicines, the Hglt2 inhibitors, sodium glucose cotransporters, and there's about 4 of them, I think, on the market now. They all end in Flozin. If you're looking at the generic names of them, that's how I remember things. Order me a Flozin.
Yeah.
And these medicines have the dual effect of both lowering glucose in the blood, and that's beneficial for hemoglobin A1C and diabetes control in general. And they seem to have a real positive effect on kidney function itself. When somebody is hyperglycemic, when chronically hyperglycemic, they tend to have a lot of oxidative stress that occurs both at the glomerular level, but also in the tissue around the tubules, the peritubular region of the kidneys. And we're seeing that the patients that get on these medicines, the SGLT2 inhibitors, early, especially before their kidney function has really declined, they then tend to have a better overall course over time. So real benefit there. There's a class of medicines that's been around for a while, the aldosterone antagonists. There's new medications in that class that have also been demonstrated to be beneficial for patients with diabetic kidney disease. And then I would say that there's an importance also in not just looking at what are the right medicines for patients to be on, but equally, what are the medicines that patients should not be on? And unfortunately, some of the over-the-counter medications that people take, ibuprofen as an example, can exacerbate different types of kidney disease, and it can exacerbate diabetic kidney disease. So as a physician, as either a nephrologist or a primary care physician or an endocrinologist, taking a look at what meds we can put the patient on to help them have a better clinical outcome, and equally take them off of certain things to help with that clinical outcome, I think that's where we find the sweet spot.
Yeah, perfect. And this sort of segues into one of the questions somebody asked. So who takes care of these people? And what's the relationship, and when does the nephrologist come into play?
This is variable, and it's variable by who the patient is, what stage of kidney disease or diabetes, how they're doing there, what is the complexity, what community do they live in. I would say that the vast majority of Americans with diabetes and early kidney disease are managed very, very appropriately by their primary care physician, by their internist, by their family practice physician. As somebody progresses, though, and this will vary a little bit on the community, but when they hit about CKD stage 3A, which is a GFR below 60, or in some communities, CKD stage 3B, which is a GFR below 45, I do think it's important to get the nephrologist involved. There become some complexities with the ACEs and ARBs and the aldosterone antagonists and potassium and metabolic acidosis that a nephrologist is eager to try to focus on. I always like it when patients are referred earlier rather than later. I think there's benefit there. But the benefit comes not only in having a nephrologist or an endocrinologist, but in everybody in the team working together. It doesn't work if the nephrologist is siloed from the endocrinologist, who's siloed from the cardiologist and the primary care physician. That doesn't help. What helps is when you can communicate with one another and make sure that we're pulling in the same direction.
That is key. And so somewhere between 45 and 60 GFR, time to reach the nephrologist and get them involved. So I'm going to sort of follow this progression, and sadly, many people are not diagnosed early. They don't get these treatments, and I think we've all sadly seen people show up in emergency rooms, with end-stage renal disease, and it's obviously something we want to avoid. But what are the options now, and talk a little bit about that.
Sure, Tina, you want to take first stab at it, and then I'll jump on in terms of people that crash into dialysis, show up at the hospital with kidney failure.
Sure. So there are several options, one of which is obviously to receive dialysis treatment within our in-center or outpatient dialysis clinics that are throughout the country, throughout the United States. And then there are other options, and that's also called hemodialysis. So that is a treatment option where the care is actually provided by healthcare professionals within the walls of a standalone building. There are other options that patients can choose from, which honestly is, and transparently, is my preferred options. I would choose for myself as a patient. And those are home therapies. And that is where patients can work with their healthcare provider and their care team to choose to provide dialysis at home within the comfort of their own home setting. Of course, with the support of their healthcare team at large, that are readily available and accessible. And there are two different types of home therapy options. One is called peritoneal dialysis, which is where we actually use the peritoneum membrane of the peritoneal cavity as the filter to clean the blood. And I think what a preferred option for patients as it relates to that is it requires no needles in the arm to actually access a blood source. And so our patients typically love that because it's needleless. And then the second option is called home hemodialysis. So same process as hemodialysis on the in-center, in chronic side that they're able to do at home with the help of a care partner.
And our goal is to never get to that point. I mean, our goal is not for patients to show up in the emergency room not knowing that their kidneys were failing and, oh my gosh, it's an emergency. Because at that point, and typically this happens at 2 a.m. on a Friday night, Saturday morning, it's so disruptive to that person, to their life, to their family. Our goal is to make sure that we're helping people have access to care well upstream, so that A, we can stop the decline or slow the decline of kidney dysfunction. If somehow we can't slow down the decline and it's obvious that they're moving on to needing more and more support because of kidney failure, then we want to make sure they've got all of the right education, what we call CKD or chronic kidney disease education that's available in the communities. We want to make sure that they're evaluated preemptively for a kidney transplant. And where appropriate, we want to make sure that we're having those more difficult conversations about end-of-life care, patient choice, things along those lines with regard to shared decision-making. Because when you show up in the emergency room with kidney failure, while there's still sharing of decision-making, the number of options is very, very limited.
Yeah. And that really is what needs to be avoided. So the time is just like flown by. Thank you for sharing all of this good information. I might ask each of you to just share a last comment to the audience. We've covered a lot of ground. An ounce of prevention. This is very much that kind of story. So Tina, I'll start with you, and then Dr. Jeff.
Yeah, I would just say that, and we've mentioned this along the way, or I have in particular, is I would just implore our healthcare professionals to empower our patients to make informed choices. And so there's plenty of tools and resources that can assist you and our patients in doing that. One of which is what Jeff mentioned, our kidney education classes. So you can find that through DaVita.com. Kidney Smart classes are no-cost education classes that are available to anyone in the community. And so the opportunity to have patients access those is just a tremendous gift for them to understand their risk factors, but also make informed decisions.
Yeah, and I'll just say to my physician colleagues out there and medical provider colleagues out there, thank you for joining. Thank you for thinking about this disease. It does take all of us working together. And then for the patients or not patients, just individuals out there watching, I just encourage you to be proactive. Somebody just asked on the chat line if I could tell them more about ibuprofen and diabetes. Ibuprofen is a medicine that changes blood flow in the kidneys, the way it flows through. And so it can exacerbate any type of kidney disease. But these are the types of questions, this proactive approach are the types of questions that I would want people talking to their physicians or talking to their nurse practitioners or their physician assistants about, because the more that we're talking about this stuff, the more we can jointly combat this disease.
Absolutely.
Thank you. On behalf of the American Diabetes Association, I thank both of you for taking the time to educate all of us about chronic kidney disease, what we can do to prevent it, how we can treat it. This is American Diabetes Month, so it's all the more appropriate that we talk about this. Thank you for the audience for joining us. Please, 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 implement what we've talked about. Screen people early, treat them appropriately, empower your patients. Together, we can really prevent kidney disease, and that's our goal. So thanks, everyone, for joining, and we'll see you next time.